All right, hello everyone. Looks like we're still just getting all of our high technology working. Okay, fantastic. Thank you so much, Rachel, and thanks everybody for being here. Welcome to this beautiful end of September time. We're going to have some really fantastic presentations from our postdocs today in the PSC postdoc program. And what we're planning to do is I'm learning about all the buttons here from our experts. We're planning to have each speaker present for about 10 to 12 minutes with slides, and then we'll have time for a few clarifying questions or just points that you want to bring up with our presenters in the moment. And at the end, we might have enough time for some further Q&A. I'm sorry to say that one of our postdocs is having a family health emergency, so won't be presenting, Josh Good, but hopefully we'll be able to catch up with him later in the semester. And I also just wanted to remind folks that next week, October 3rd on Monday, same time, same place, Emma Zhang is going to be here from Yale. And so at this point, I would like to turn it over to my colleague, Matt, who's going to come up, and I'm going to advance the slides, hopefully, or he's going to do it. Come on up, Matt.
Thanks.
Here, just a shot for this.
Intro. Okay, cool. So I'll be pointing this at Sarah's computer. Hi, everyone. So I'm Matt Esner. That's me. I just received my PhD in economics from Vanderbilt University. In August, it was conferred. So just now. And broadly, my research focus is at the intersection of labor, health, and public economics in the context of US economic history in the 20th century. So I view my dissertation as broadly answering two types of questions. First, how do social insurance programs affect individuals' economic and demographic choices or outcomes? And second, how do different programs administered at various levels of government, so local, state, and federal governments, interact in shaping the scope and generosity of these programs? So to set some context, many of you will be familiar with the Social Security Act of 1935. All of the primary programs that transfer resources to individuals at all stages of their life can trace their roots, or many of them can trace their roots to the Social Security Act. And through enabling federal financing or federal funding, it not only facilitated tremendous growth in these programs, but also set the stage for a host of other expansions over the ensuing remainder of the 20th century. So that in 2019, roughly 70 million Americans received some sort of a program administered through the Social Security Administration. So my projects all study programs that are created by or in conjunction with the Social Security Act. And I combine historical data with efforts to find and digitize novel data sources that contain information on the programs of interest, so recipiency or benefit levels or benefits per recipient, on the people that are affected by these programs and the governments that provide them or administer them. And then I combine this with natural experimental settings and quasi-experimental techniques and some economic theory, of course, to answer questions. So let's get into it. The first chapter of my dissertation is motivated by one historical fact, which is the 20th century decline in elderly labor force participation, 65 and older. So in the turn of the 20th century, roughly 65% of men in this age group could have been expected to be working in the labor force. And at the turn of the 21st century, that was closer to around 20%. Okay, and there's been a large literature in the social sciences trying to explain this. And naturally, a lot of that has focused on the rise of public pensions and in particular, Social Security, which I'll show you in a moment. So I'm going to be trying to add to this literature what was the impact of public pensions in driving this decline by studying a novel program that's quite similar to Social Security, called railroad retirement benefits. So I studied the introduction of these benefits in the mid-1930s. Okay, this was a reform that nationalized all private pensions in the railroad industry, which was one of the largest industries at the time, comprising something like 5% of non-agricultural employment. And these were quite generous benefits, both relative to contemporaneous other pensions and relative to today. So the average benefit was something like 4 times median rent. Okay, that's much higher than Social Security is relative to the cost of living today. Okay, and I view this as informing what we can learn about Social Security expansions in ensuing decades, because the programs were quite similar, but there's some differences in their introduction that I won't get into here, but you can always look at my website and the paper if you're interested. And the program still exists today, which I did not know when I started working on this project. Railroad workers do not pay Social Security taxes. They have their own retirement benefit tax and benefit scheme. Okay, so I find that it decreased labor force participation among elderly workers, and this can inform our understanding of broad expansions to the Social Security program in ensuing decades. So moving on to the second chapter, this is motivated by the idea that oftentimes when you expand or introduce new programs, they crowd out recipiency or payments in other programs. So this has been shown to occur between the precursor to TANF, the AFDC program, and supplemental security income and other social insurance programs. Okay, and this has a couple implications, which depending on how governments respond, it may be that the overall size of the safety net does not increase to the extent that nominal increases in the safety net by looking at the new program would suggest. And it'll also oftentimes mean that the costs are much smaller, but it's interesting to see who saves from these programs. Okay, so in joint work with Dan Feder at Stanford University, we studied the displacement of elderly public assistance with Social Security. So here on this graph, I've plotted, here, can I move? Here I've plotted basically the increase in Social Security per person 65 and older. This is payments per person 65 and older in real terms. And then in the red line, it's elderly public assistance, which was phased out in the 1970s, but was a quite important program right after the Social Security Act. So to address current need in the wake of the Depression and the wake of the New Deal, this other program, which you can think of as welfare for the elderly, it was means tested, it was cash assistance, was much larger and was paid to roughly 1/4 of all elderly individuals in 1940. Okay, but as Social Security grew, especially after the 1950s, it displaced this program. And there was highly heterogeneous effects in this displacement across states, depending on who was covered by Social Security at what time and how much benefits they were getting in relation to the means tests of these welfare programs. Okay, and so this has 2 implications. One, just looking at the increase in Social Security would overstate the increase in resources to the elderly. And 2, well, if the federal government was spending more money on Social Security and it was displacing this other program, where did that money go? And I guess I didn't mention this, but the welfare programs typically in the 20th century were jointly financed by various levels of government. And so a lot of these savings are going to accrue to other governments, notably state governments. Okay, and so kind of in a provocative finding, due to just the fact that I guess vice taxes were often viewed as like worthy to be earmarked for welfare expenditure, this ended up, we're finding, led to decreases in liquor tax revenue. So states save money and they cut liquor tax rates. And we're still investigating what the impact of this was for individuals, okay, because Social Security is a lot more race blind than some of these welfare programs were, especially back then. And so that's something that we look forward to investigating further. Okay, and then in my last project, I switched to the opposite end of the life cycle and study single parent family targeted welfare and family structure dynamics. So under the precursor to TANF, the Aid to Families with Dependent Children program, between 1936 and 1960, if you were married, you weren't going to receive benefits under this program, regardless of the need of the children or the family. Okay. In 1961, this was reformed, to include an unemployed parent segment of the program, which effectively allowed two-parent families who were married to receive cash welfare if they, met the means test and had, dependent children, if the main breadwinner, oftentimes the father, was unemployed. Okay, and so I study what is the impact of this on marriage and divorce behavior, what is the impact of this on fertility, by marital status. Okay, and this is still very much a work in progress, but I'm finding suggestive evidence. Sorry, Sarah, could you get this on? Well, some suggestive evidence that there's declines in non-marital fertility among non-white women. This is how it was classified on the birth certificates, white and non-white at this time, so I cannot look into any more, specific racial groups. But I'm finding some suggestive evidence that this caused reductions in non-marital fertility, and this is broadly consistent with, higher recipiency among non-white groups in welfare programs in this period. Okay. And so going forward in the next 2 years during my time here at UM, I hope to keep working on this dissertation and, to get these things published, fingers crossed, and then to engage in new projects. And I've really been thinking a lot about the impact of pensions on longevity, both on recipients themselves and in an intergenerational context. And, for this, I was thinking a lot about Josh's presentation last week and the Sensoc data, which could be very, useful here to study, children's long-term outcomes from parents who may have received generous pensions. Okay, and if you are interested in any of this work, you can feel free to visit my website at matthewpesner.com and trying to become more active on Twitter. So that's my handle. How was that on time?
It was perfect.
Okay, thank you.
So hi everyone, my name is Emily Parker. I am an NIA postdoc entering my second year with the PSC. My fabulous mentor, Natasha Pakaskis, is on the call as well. So I completed my PhD in policy analysis and management at Cornell in 2021. And kind of at the highest level, my research interests are in health and social policy, poverty and inequality, gender and family, and spatial demography. But more specifically, my research is really focused on how public policy and community context shape population health and social inequality. So I have kind of 3 buckets of research in this area. The first in my primary research area is on the US healthcare safety net. The second is on federal place-based policymaking, and the third is on race, gender, family, and public policy. I'm getting some chats here, so I'm just gonna, okay, you're all good. So I'll tell you more about my progress in these areas, but first I want to just acknowledge the tremendous support I've received from the PSC in enabling me to attend many conferences in the last year, which has been just an absolute joy being able to be in person again at PAA, ASA, Social Science History Association, and APAM. I had many opportunities to present my work and get feedback, as well as to grow my professional network. So many thanks for that support, as well as receiving a PSC small grant through the Marshall Weinberg Endowment Fund. So I appreciate that research support, as well as UM's Postdoctoral Association, which very generously has funded some professional development opportunities for me. So now I'm going to dive into my research progress. So my main area of research building out of my dissertation is on the Community Health Center program, which originated in the 1965 War on Poverty, and has the goal of opening primary care clinics in medically underserved areas. And what makes community health centers different from other healthcare entities is that they are required to serve anyone regardless of ability to pay, as well as linguistic ability, legal status, and a host of other areas that they really are the place to go if you have no other options. So you can see in this map here, which is part of the data I collected for my dissertation on the geography of the health center program. It now serves roughly 30 million patients, and they're predominantly low income and racial and ethnic minorities. So the program has expanded tremendously in the last 20 years or so. It's tripled since 2000 in federal funding as well as patients. So it's, a really significant policy area that, not many social scientists have paid attention to, except for some former PSC affiliates who I'm citing here. So I'm really hoping to build out this research area on showing how these clinics are impacting population health. So the works I have in progress, two of which kind of trying to get published still for my dissertation. The first one is tracing the political and historical development of the healthcare safety net. And the second one is evaluating the kind of qualitative experience of attending the safety net clinic setting. But in the last year, I've added two new projects through my postdoc training that are really trying to further examine the role of community health centers on population health disparities. So I'm going to just talk more about what I'm finding, and these are, very preliminary works in progress. But basically, I'm building on my prior work that I published for my dissertation, which found that community health centers are far more spatially proximate to poor and foreign-born Hispanics than they are to other population groups. And this is really important because Hispanic immigrants are disproportionately uninsured due to being excluded from public programs like Medicaid, which means that community health centers are really one of the only sources of care for this population. So in one paper I've developed over the last year, I ask whether the geography of the community health center program contributes to variation in mortality for different racial and ethnic groups. And so I linked this historical data that I have on community health centers with CDC Wonder's age-adjusted mortality rate, and exploiting variation in the treatment of counties that did and did not receive funding despite being eligible to do so. So I don't have time to get into the nitty-gritty, but the initial results do suggest that from 96 to 2017, community health centers have attenuated the Hispanic mortality rate. And this translates to about 100 fewer deaths per 100,000 of the Hispanic population, which is a non-trivial reduction as far as mortality effects go. So I'm still, working through these results. But I think that the kind of next step from my paper is to really try to understand whether community health centers may be one mechanism that partially explain the Hispanic health paradox. So scholars in this area have generally focused on the importance of health insurance as an indicator of access, but these findings underscore that community health centers should also be incorporated into how we measure healthcare access and outcomes for immigrant populations. So another paper I've developed in the last year with co-authors Courtney Bowen and Rebecca Shute look at how community health centers shape healthcare access and outcomes, specifically among the migrant and seasonal farm worker population across varying legal statuses. So I'm really excited about this paper. It links my community health center data with the NAS, which is a long-standing survey of migrant and seasonal farm workers since 1989. And the really cool thing about this data is that it has a very reliable measure of legal status, which is, as many of you know, is very difficult to identify in survey data. So you can see here, this is just one figure showing the density of community health centers in the counties of residence for undocumented versus documented and citizen farm workers. So these are preliminary results that we're planning to send to PA next week. But we do find substantial variation in farm workers' proximity to health centers and serious deficiencies in new immigrant destinations such as the Northeast and Midwest. I am putting up a little map here so you can see Michigan's migrant health center distribution and how rather sparse it is. We do end up finding in our regression results that community health centers are associated with improved access to care for undocumented and foreign-born farm workers. This means that they're more likely to have both received medical care in the last year and less likely to report barriers to care, specifically linguistic barriers, which are very important when going to the doctor's office. So our next step for this project is to examine health outcomes, but these preliminary results do suggest that healthcare safety net is playing an important role for undocumented farm workers in accessing healthcare. So future directions for this line of my work, I plan to continue building out research on how health centers impact socioeconomic, spatial, and racial and ethnic health disparities. I plan to also study the interactions between state Medicaid policy and community health center access over time, and to continue to examine the population health implications of the health center program's targeted initiatives like migrant seasonal farm workers, which are a special population group, as well as other initiatives they have. And finally, I do plan to do a study on COVID-19 disparities and if communities that had better safety net infrastructure fared better in various pandemic outcomes. So moving to another area of my research with Laura Tack is on federal place-based policymaking. And these policies target areas of concentrated disadvantage. So we have a number of projects in this area at various stages, but we're trying to understand the spatial distribution and effects of these policies. So we had 2 papers come out in the last year on this topic. The first was on federal place-based policymaking in rural America, and a substantial increase in these policies going to rural places. And through linking with the NLSY, we also find that this investment was associated with improved socioeconomic outcomes for young adults, but only young adults who moved out of their home county. And then the second paper looked at historical redlining, and we do find that place-based policies, substantially more place-based funding went to formerly redlined areas, which was associated with increased property values, but reductions in the share of Black homeowners. So both of these projects kind of we're trying to answer the question of who is benefiting from federal investment in disinvested communities. So natural extension of this project, and I'm also very excited about this paper, we are looking at whether place-based funding was actually induced gentrification in low-income areas. So we do find support that economic development policies were associated with increased odds of gentrification, but not federal place-based housing policies. And this result definitely surprised us. So after multiple kind of sensitivity analysis, looking for the mechanisms here, we ultimately conclude that these affordable housing policies mitigated rapid class turnover in historically disinvested communities due to the production of increased production of low-income housing. We also find that our results are patterned by racial stratification of urban neighborhoods, in that the majority Black and Hispanic neighborhoods were both more likely to receive investment and experience state-induced gentrification, as well as experience elevated losses of racial minorities. So the results suggest indirect displacement. And to dig deeper into one of these economic development policies, we also have a paper looking at the Federal Empowerment Zone program, which dates back to the 1990s. And I won't go into depth, but basically we do find that there are long-run effects on lower poverty, higher employment, and higher property values associated with the Empowerment Zone program, which had a particularly protective effect during the Great Recession. But again, we find evidence of displacement. Okay, and moving to my last area of research on the intersections between race, gender, and family. So I published some papers on changing trends in modern union formation, as well as racial and ethnic differences in the role of fatherhood. I have a collaborative project looking at how local housing markets are associated with cohabitation and marriage. And I've also collaborated on a large-scale mixed method study on retention of underrepresented minorities and women in STEM. So ongoing work in this area as well. I'd be happy to talk more about. And looking to the future, what's next? I'm very happy to share some exciting news from the past year that I received a tenure track job at Rutgers University in the Blaustein School of Planning and Public Policy. So I was lucky enough to be able to defer a year to finish my postdoc. And I have the luxury of enjoying a wonderful year at the PSC without being on the job market. But I'm very much looking forward to joining Rutgers next year. So thank you all for listening. I look forward to connecting in the future.
Thank you, Emily. And those claps are for you too, Matt. Anybody have any quick questions for Emily at this point? Otherwise, those of you online, it didn't look like it. Except, yep, that's a clap from waiting. Okay, fantastic. I think we'll then turn it over to Margaret, who will be next.
Great. Thank you, Emily and Matt. I really enjoyed both of those presentations. Let's see if I can get my slides up. Thinking about it. Man, I'm really hoping I'm not displayed on the screen there in the conference room like 5 foot by 6 foot. If so, if so, be thankful I brushed my hair, but also my apologies.
There you go.
See if I can get my little. It's just a moment. Okay, does that look okay?
It looks good. Yep.
Great. Again, my name is Margaret Whitley. I'm a second-year postdoc fellow in the NIA-funded postdoc program. And I wanted to thank Sarah and everybody else who put this together. It really feels like an honor to get a chance to just come and talk about myself in front of a fantastic group of folks at ISR and maybe beyond. You may have noticed that all of us second-year postdoc fellows are doing our postdocs remotely on account of the pandemic and all the complications that caused. So I did have the opportunity to come visit Ann Arbor and ISR, and it was fantastic, but I'm not getting to wander around the hallways and meet folks in person quite as much as maybe I would be doing ideally. But I will say people at ISR have been so responsive and willing to meet via Zoom, and that's been really nice. So I'll continue to bug people and hopefully connect with folks that way. So I'm going to keep it pretty brief and just touch on some highlights from the past year. But by way of background, I'm a population health researcher and my training is in public health. But prior to doing the PhD, I also completed degrees in community health and in social welfare. And those really serve as the foundation for the kind of research that I'm focusing on. I'm mainly interested in population health inequities and the way some of these complicated social structures are shaping our health behaviors, our health environments, and translating into health inequities. And I'm especially interested in work and working conditions. And in this postdoc, I am very fortunate to have Sarah Burgart as a mentor. So updates from the past year, and I'm going to focus again on my main line of research, which again is the working conditions and health disparities work. I do have chances to dabble in other public health and health services topics, but this is the stuff I'm most excited about. So the updates from this year really stem from my dissertation work that I did at UC Irvine, where I focused on how working conditions relate to breastfeeding outcomes among working mothers. And just a couple months ago, published an empirical study about job control and breastfeeding disparities in the United States, and that was published in Journal of Occupational and Environmental Medicine. And I used data from the panel study of income dynamics, also known as the PSID. So even before coming to this postdoc, I was getting my fingers into ISR life, and was very thankful to have access to that data set because there are actually very few data sets out there that have detailed information about breastfeeding outcomes and also detailed information about mother's occupation, but PSID has that. So I looked at job control. I should say job control. I had to bring in that measure from an outside source, but job control is a psychosocial working condition that refers to the amount of decision-making latitude and flexibility that a given job affords the person who's doing the job. So it's not a characteristic of the worker, but rather that particular job or occupation. So social scientists, for example, have pretty high job control, and you may have lots and lots of work to do, but you have a lot of flexibility in decision-making most of the time, and decision-making latitude in terms of how you get that work done. But if you think of like somebody working in an Amazon warehouse, for example, or a cashier or a bus driver, they have lower job control. And so what I'm arguing in this paper is that having lower job control translates into shorter breastfeeding because it makes it difficult to do all of those things that are involved in continuing to breastfeeding for a mother who's gone back to work, especially early on after the child is born. And Black mothers are disproportionately exposed to lower job control relative to white mothers because of occupational segregation and discrimination and all those steps that lead to how people get the jobs that they have. And so we did find in the study, in using PSID data and path modeling, that lower job control explained roughly a third of the differences in breastfeeding duration between Black and white mothers. And this got picked up on by a couple people in the Twitter sphere, fewer than 10, but Matt, you're a step ahead of me by actually being on Twitter. I'm not even there, but I was still happy to see that somebody was commenting on it. And there was a comment that from an occupational medicine physician that, the study showed that what happens at work has implications for the entire family. And I was really pleased by that, because that's what I'm trying to demonstrate with this work, that I think we know intuitively that our working conditions impact our own health and well-being in the short term. But there's really good reason to believe that it's impacting our health and well-being, throughout our life course, and also for our families and even broader communities beyond that. And kind of hand in hand with that empirical paper, I also just had published a literature review and conceptual framework that provides the sort of theoretical grounding and empirical grounding for that work on working conditions and racial disparities in breastfeeding. And that was in the New Solutions Journal of Environmental and Occupational Health Policy. And so now work that's ongoing, I'm really pleased to have the opportunity as part of this postdoc program to keep building on this line of inquiry, but focus on the adult population in general, not just working mothers, and now take a look at a broader range of working conditions. And looking at health disparities in self-rated health and some other outcomes that are more relevant for the entire population, not just new parents and infants. And I'm again using PSID. I just can't let go of it. They've got these great new variables that started disseminating or using in, I think, 2017, that ask about the extent to which a worker feels pressed for time, how much kind of substantive complexity or intellectual demand their work has, physical demands, and then some more standard questions around hours that people are working per week, and also the size of the organization that they're working for. So I'm looking at how all of those may help us understand racial ethnic disparities in self-rated health. And I had the opportunity, also with really generous support from the postdoc program, to start disseminating some early results from that first this summer at the Work Family Researchers Network Conference, which if anybody's doing work family research and you haven't heard of that conference, it's really worth checking out. It's a great, very interdisciplinary group of people. And also be sharing a more evolved set of results at American Public Health Association's meeting this November in Boston. So hopefully I can see some people there. And also this work on working conditions and racial and ethnic disparities in self-rated health served as the kind of groundwork for my application to the NIH loan repayment program, specifically the program in health disparities research. And I was happy to say that that was accepted, which is of course great news for me and in getting rid of some of those student loans. But I also think it speaks to the fact that NIH is now really recognizing the role of working conditions in helping us to understand health disparities. So I'll put in a plug for the NIH LRP program if anybody out there is doing health research and is still sitting on some student loans. It's really worth looking into. And I also want to mention on a different note that within this postdoc, I've had the opportunity to be involved in the ISR Diversity, Equity, and Inclusion Educational Programs Working Group. And it's really been a fun thing to be involved in. They've put on a number of talks under the umbrella of inclusive research methods, but dealing with a lot of different kind of specific topics around how we can be more inclusive in the way that we conduct research. And they're all publicly available online on the ISR website. So I recommend folks check that out. And I'm helping to lead an effort in getting into the literature so we can be a little more intentional about what we mean when we say inclusive research methods, and aware of some of the kind of classic works in this area and people who've already made big strides in redefining paradigms. And some of the most interesting work under the term inclusive research methods seems to come from research with people with learning disabilities. So that was a really interesting piece to learn. But yeah, a plug for this working group. It's been a great way to get connected with folks at ISR, particularly as someone working remotely. So I'm going to end it there, but I hope to have a chance to connect with some of you in the future.
Much, Margaret. It has been my entire pleasure to be working with you during your postdoc. And I'm glad that you brought up the loan repayment program, as well as the DEI work that's going on here at ISR, which we'd be delighted to have all of you involved in some fashion. I'm going to turn over. I didn't see any questions in the chat, and I don't see anybody jumping up and down momentarily. So I think we'll turn to our last speaker for the day. Widdy, we're going to let you take it away.
Yeah, thank you, Sarah. Let me share my slide. Okay. So I can't see anyone here. If you have any questions, feel free to leave in the chat. Good afternoon, everyone. My name is Widdy Cheng. I'm a second-year postdoc at the Population Studies Center in the NIAT 32 program. So first, I want to thank you all for this opportunity to share more about myself and my research. So here's the outline for my presentation today. So I want to talk about my research and training background and provide a summary of my first-year activities at PSC and my plans for the coming year. So in terms of my training background, as a postdoc at the PSC, I work with my mentors, Drs. Mazuk and Dr. Needham, at the School of Public Health on projects related to diabetes management, care coordination, and telomere length. So one example of our projects is the discrimination, social support, and metabolic syndrome. I'm going to identify the racial and ethnic differences in the associations among these mechanisms. And we have been approved by using the data from the multi-ethnic study of atherosclerosis. Before I joined PSC, I completed my PhD in social welfare at Case Western Reserve University and my master's degrees and my dual master's degrees from WashU. Throughout my education and training, my interests have been focused on aging and health. In particular, I want to study management of cardiometabolic diseases in later life and how that impact older adults' independent living in the community. I want to identify the psychosocial determinants influencing the mechanism linking cardiometabolic health to disability. I also developed interest in minority aging among racial and ethnic minorities. So far, my research activities have contributed to two primary research areas. The first one is the biopsychosocial mechanism of cardiometabolic health and independent living among older adults who live in the community. So specifically, I want to identify the modifiable psychosocial, protective, and the risk factors of the development and onset and the progression of cardiometabolic diseases and how that influence older adults' daily activities. The goal of this line of research is to identify these modifiable factors to inform interventions and the practice and services to serve older adults to help them effectively manage chronic disease and to prolong their ability to live in the community as long as possible. Because it's inevitable that at some point, an individual will have to stop driving and will no longer be able to get out of bed independently. So my goal is to prolong the independent living as long as possible. And here is a list of my selected of publications that speak to this topic. The second topic is closely related to my first topic. So I'm interested in examining social stressors and the health outcomes among older African Americans. The reason is that older African Americans face a distinct set of social stressors that have adverse effects on their health, such as structural racism, residential segregation, everyday discrimination. Like these are the unique challenges that older African Americans facing on a daily basis. So my goal is to identify how these distinct stressors influence the older African American health and what are the potential coping resources we can mobilize to help this population. So here's a list of my selected publications that speak to this topic. So next, I want to provide a brief summary of what I have accomplished in my first year at PSC. Publication-wise, I published 8 peer-reviewed journal articles, including 4 first authored. I presented oral papers and posters at national and regional conferences. I also received a small research grant from the ISR Next Generation Initiative. So I'm going to use this grant to examine neighborhood social support and inflammation among older adults using data from the health and retirement study. I also attended quite a few training and professional development workshops and programs, which are very helpful to advance my research agenda. So of all the papers I have published in the past year, there are 3 studies I want to highlight. So the first study is visual difficulty and activity limitations and neighborhood characteristics. So this study was conducted in collaboration with Dr. Clark and Dr. Ehrlich at the Survey Research Center. So in the study, we examined the link between visual difficulty and daily activities and the moderating effects of neighborhood. So the link between visual difficulty and daily activities are highly established, but one limitation is that people tend to use a binary measure of visual impairment, like whether this person has impairment or no impairment. So a binary measure cannot capture a more detailed spectrum of the extent of the visual difficulty. So the novelty of the study is that we used a more detailed measure of visual difficulty, like people who have near difficulty only, distance difficulty only, or both, or being blind, and the people without any difficulty at all. So for this study, we used the data from the National Health and Aging Trend Study, and we applied multiple imputation to address missing data. And we identified the moderating effects of neighborhood. So specifically, we found that neighborhood physical disorder can exacerbate the adverse effects of near difficulty among activity limitations, which are self-care activities and household tasks. So findings from the study have provided implications for community level efforts to promote visual care, such as a rehabilitation of vision. How can we address some neighborhood, physical aspects of neighborhood to ameliorate the adverse effects of visual difficulty on independent living among older adults? So the second study I want to highlight is about oral health and mortality. So this work is done in collaboration with the researchers at population centers in other universities at Minnesota and Johns Hopkins. So we also collaborated with a dentist at University of Michigan. So for this study, we used the data from NHANES, and we used a 27-year mortality follow-up to perform our analysis. And we also applied inverse probability weighting to account for selection bias and the missing data. We identified that different aspects of oral condition is associated with a different extent of mortality. So for example, edentulosum is most salient in predicting mortality, while periodontal and dental caries are less severe, but also significantly associated with mortality outcomes. So this work highlighted the importance of meeting the dental care needs among older adults, especially those with disadvantaged and low socioeconomic status older adults. A third study I want to highlight is based on my dissertation. So the study, I examined the effects of a diagnosis of diabetes on health behavior maintenance using data from health and retirement study. So essentially, I found that a diabetes diagnosis has a dual effects on people's subsequent health behavior changes. So for some types of health behavior, such as drinking, a diagnosis of diabetes is a teachable moment, means that it increases people's perception of risk in their unhealthy behaviors, and thus they are more likely to engage, to adopt, and initiate health promoting behavior, such as reducing their drinking amount. And on the other hand, a diagnosis can also be a stressful health event that negatively influence people's behavior. So I found that following a diagnosis, people are less likely to maintain their physical activity levels. So this research informs the practice that upon the diagnosis of diabetes, patients should be referred to a diabetes management program as soon as possible to receive the resources because this is the time that the effectiveness of the intervention can be maximized. So next, I want to share some of my involvement on campus. So I have participated in quite a few training and workshops on campus in my first year, and one of them is Macquarie. So I was a postdoc scientist with Macquarie in the last year, where I have received intensive mentoring in terms of substantive areas and the methodology on African American aging. So in particular, I now primarily use a within group analysis to analyze the risk factors that are distinct to older African Americans, because this is not a homogeneous population, and we need to generate a knowledge that is unique to this population. And for outcomes from my participation in Macquarie, I collaborated with a couple other Macquarie scholars on one manuscript, which is ready to be submitted in October. Also, because of the resources from Macquarie, I will also incorporate my mentoring and the resources at Macquarie in my KO1 grant proposal. A second experience I want to share is my participation in MIWI. I was extremely lucky to be selected as one of the 5 scholars in the MIWI program last year. So in MIWI, I was matched with mentors who share common research interests with me, particular diabetes, and received mentoring in content areas and the methodologies and the minority health research. So outcomes from my participation in MIWI, we submitted a pilot grant application to American Diabetes Association, and my role in the grant application is a co-investigator. And also in collaboration with the MIWI scholars, we are going to present an oral paper at the GSA later in December. And also because of the support letters from my mentors through MIWI, I was selected to join the NIDDK training workshop on diabetes or health disparities. So last, I want to share another experience I want to share is my participation in the genomics social scientist. This was a 1-week workshop that was very intensive, but I had a great time. I met with the people from different disciplinary backgrounds. And one potential outcome from this workshop is a paper on discrimination and telomeres. So I'm still waiting for the telomere data, for 2016, which I think will be released sometime soon. Okay, so next, my plans for the coming year. So my top priority is to get a job. So right now I'm on the job market. I'm on the job market. I'm seeking a faculty position in social work. So I'm actually going to have my first interview with one of my dream schools on Friday, and I'm preparing for that. So apart from job seeking, I will continue work on grant application, both internal, external grants, and continue working on publications. So my goal is to publish 10 papers, including 5 first author, and continue working on conference presentation. I'm working on a PAA abstract, which is due next week. So last, I realized I have only 2 years at UM, and I thoroughly enjoyed meeting and working with many scholars here. I want to continue building a network of interdisciplinary scholars on University of Michigan campus, and hopefully I can carry forward these collaborative relationships into my future career, because I highly value these collaborations. Yeah, so that's all about me. Thank you for your attention.
Thanks so much, Wendy. I think that you got just a brief sense of just how outstanding our postdocs in the program are and how much incredible work they're doing. And so I really want to thank all of them, and to thank them for presenting information about grants and trainings and other things you've gotten involved with while you've been on campus that other people might find useful and interesting as well. I also just want to say that it's the work of people like this that helped us to get our training program refunded for the next 5 years. We just got all of that information finalized. So the pre-docs in the room and on the call, and the postdocs it's the work you've done that really made us shine, and saw the reviewers really saw how outstanding the work is. So thank you all for presenting and putting up with our technical difficulties. Thank you, Rachel, for providing lunch. Remember, we actually have food at these things now, so come on down if you can. And I will see everybody next week for Emma Zhang from Yale. Thanks, and have a great rest of your week.